Hi, my name is Lori Bechard, and I'm a registered dietitian and professor, and I specialize in clinical nutrition research in pediatrics. This course is just one in a series of modules on indirect calorimetry brought to you by Channel 1, on-demand nutrition education. This module is part 3 in a 4-part series. We are focusing on pediatrics. Today, we are looking at interpretation of results in indirect calorimetry. The objectives for this session are to examine and interpret indirect calorimetry data and to understand this interpretation in the context of patient care. We will accomplish these objectives through 2 case scenarios. The first case is a 16-year-old male with no significant history who was admitted following multiple trauma related to a scooter versus motor vehicle accident. He had a Glasgow coma score of 3 on the scene with reported posturing and was intubated in the field. He underwent cranial surgery with intracranial pressure monitoring for his traumatic brain injury, or TBI. He remained mechanically ventilated on IV fluids, paralytic agents, sedation, and pressors for the first few days of hospitalization. His energy requirements were calculated at 1.3 to 1.5 times his basal metabolic rate, estimated by the Harris-Benedict equation. He had persistent fevers throughout the admission attributed to neurostorming with his severe TBI. About a week later, he was noted to be losing weight and IC was completed. The results shown here suggest a normal REE at 95% of that predicted with an RQ of 0.81. The steadiness of the measurement points looked good over a 10-minute testing period with minimal variability and steady state achieved. There are no red flags in these results suggesting that although the REE is normal, since the nutrition delivery exceeds that considerably, and the RQ is consistent with fat utilization and possible underfeeding, there may be losses or energy expended that is not captured by the REE measurement. In this case, perhaps the periods of neurostorming are increasing the patient's total daily energy expenditure substantially. IC was repeated 8 days later. Steady state was achieved in 10 minutes with less than 5% variation in VO2 and VCO2, and REE increased to 100% of predicted. However, the RQ is now 1.05, suggesting a carbohydrate-predominant substrate, which may be consistent with nutrition delivery exceeding the REE. Clinical findings corroborated this interpretation with elevated blood glucose and difficulty weaning from the bed. For the second case, we have a 14-year-old female with history of global developmental delay, cerebral palsy, epilepsy, spastic quadriplegia, and GJ feeding tube dependence, who was admitted following orthopedic surgery for pain control. The course was complicated by a prolonged ileus post-surgery. She was started on parenteral nutrition, and with her past history of weight gain on a hypocaloric feeding regimen, IC was performed to evaluate REE. This took place just after she was diagnosed with aspiration pneumonia while she was recovering on a hospital ward. The steady state data here confirms her hypometabolic state at 65% of predicted energy expenditure. These data might reflect a slightly higher than usual energy expenditure for this patient with a mildly low IQ. Resting energy expenditure in ill children can vary widely, and in a small single-center cohort study of critically ill children undergoing IC, 17% of patients were hypermetabolic, 55% were hypometabolic, and 28% had normal metabolism compared to standardized equations. Although the average ratio of measured to estimated energy expenditure was 95% in this cohort, there was a wide range of results, and the limits of agreements were negative 470 to positive 302 calories per day. So measurement of energy expenditure can be variable and difficult to predict, especially during pediatric critical illness, with high risk for extreme results that could lead to considerable under or overfeeding over time. The same study found that PICU physicians incorrectly estimated patients' metabolic status in 62% of cases, most often with overestimates. This figure shows a projected weekly energy imbalance based on the difference between energy intake and measured REE. And you can see the dramatic imbalances that could be caused by using inaccurate assessments of energy expenditure in this setting. These are some important points for interpreting indirect calorimetry data in children. Assure valid and appropriate testing conditions in the patient's clinical status and with their treatment modalities. always consider the clinical context of the situation. Does the result make sense with the patient's history, the estimated or assessed body composition, the current clinical status? Compare the REE to at least one appropriate calculation of estimated energy expenditure. In young children, this could be the Schofield equation. The Harris-Benedict equation may be appropriate for older children, like those in your cases. And finally, consider the meaning of the RQ and how it may confirm or refute your expectations related to feeding and energy expenditure. I would encourage you to watch other videos in the Indirect Calorimetry Channel 1 series to learn more from my esteemed colleagues on this topic. Have a great day. Thank you.